So without further ado, again, welcome to this IDC Pan-European Healthcare Executive Summit. And let me introduce to you the very first speaker. So the very first speaker is Jonas Knudsen. He's from Denmark. So apparently in Denmark, contrary to what happens in some other European countries, they have money to build new and leading-edge hospitals. And they're doing so with a big plan. And Jonas is leading for one of these hospitals, the Odense University Hospital, all of the digital components and some other components that are related to logistics and infrastructure to make sure these new hospitals actually can leverage technology to deliver more personalization, more industrialized processes, and better integration with community healthcare services and to assist patients in their home. So while I'm welcoming Jonas to come on stage, please remember, there you go. Okay. Remember, tweet about this event. It is hashtag IDCHES13. We'll put that up on the screen during the break. Thank you.
And thank you, Mac, for inviting me here at this beautiful, beautiful place, and also giving me this nice equipment here with a back and a next button. So everybody, I think, can understand the interface on this. I'm going to talk a little about the projects in Denmark regarding building new hospitals. And I think the government granted us the money before the crisis. So I guess that was lucky. And it's a change management project, not only in technology, but especially in processes, clinical processes, and on organization, and also in culture. And I don't have the solutions on what it takes to be great. But I think we have a lot of ideas, and we have designed some processes and ways to communicate about this so the change will hopefully occur. We can't take this journey alone as a public or a hospital organization. So we also invite a lot of vendors and companies in to do truly partnerships with us in order to work together and taking the journey together. And I'll talk a little about that as well. And then it's going to be great, hopefully, in 5, 10, 15 years. And that's hard to design technology with that time frame because everything is changing so fast that our clinicians can't keep up with it, and the culture and the organization certainly can't either. So the projects in Denmark, we were granted about 5.5 billion euros in Denmark to modernize the entire healthcare sector. And we were doing that by building some places new hospitals and some places modernizing existing ones. And as I said here, it's a total conversion of the Danish healthcare system, and it's going to last 10 to 15 years. And none of us have tried this before, so it's fairly new ground we are threading here. And it's really, really exciting, and because of that, it's also very much room for being innovative and also of getting new ideas. And investment is necessary. When I was a technical manager at introducing electronic healthcare record in the county of Funen, we had a lot of money to introduce new technology into existing premises. And we had that problem that we couldn't get it in. There was not enough room. And once we put all these computers inside, we needed to get more air condition, and we had to build an entire new air conditioning infrastructure in a 15-storage building. That was very, very expensive. We didn't have enough power, so we had to have some power cables from our power plant. So investments in the Danish healthcare system is necessary, and there's not a lot of patients that would actually be comfortable in 2013 of laying in those kinds of conditions. So new hospitals are, of course, with one-person rooms with your own bath and an area where your relatives can be with you. So we have 16 projects in Denmark in building new hospitals and modernizing existing ones. They are placed like this in the map. So what the state did, and that was pretty clever, I think, in order to change the way we did healthcare. They said, well, when you're gonna receive this money, you have to live up to certain standards. And one of them is we have to increase our effectiveness by 8% the year after we move inside the new building. And the years up to, we have to deliver 2%. So it's obvious that we can't give 8% the year after we move into a new building. So this is a process where we need to harvest the 8% now, and within the next 8 to 10 years, we have changed the way, as much as we can in order to live up to this. The state also said that we have to build a hospital with 20 to 30% less beds. And today, all our beds is pretty much full, and we have patients lying in the hallways and everywhere. So when the doctors saw this, they were terrified. And that's pretty obvious, because if you continue to work the way you do today, this will be a total disaster. We have to throw 300 patients off the bus from the existing premises to the new. So that we have to deal with this already now. So this is a kind of a burning platform for change in the clinical practice. One of the things the state also said that in all those money, 20 to 25% must be used on equipment. It must be used on software and digital systems and equipment. And they say that 70 of that has to be used on patient-centered equipment and digital solutions. So we are discussing right now, what is that exactly? Is that software that's close to the bed, or is it also telemedicine solutions as well? And we are discussing very much where will we go the further with this kind of money? Will it be to invest in another scanner, or where will we create this opportunity for change with this kind of money? This is a one-time opportunity for us to drive change, and we have the money. So the problem in summing up, or the key issue here is that we have some beds at existing hospitals, and the current trend is that's going downwards. But at the new existing hospital, we need to make a leap in reducing beds. So how are we going to do that? And that's a problem that we are discussing with the existing hospital. How can we make this happen? So in 8-10 years' time, we won't face a disaster. So our 10 years of development is this is a field where we're going to build a new hospital, and this is an awesome slide, I think. This is a new hospital. It's going to be built into the existing university, so you can walk from the university directly to the hospital. It's going to be integrated, and we also have to think on how can we integrate this by technology, so the doctors won't need 2 laptops, 2 separate infrastructures, etc. So how can we support research? How can we support joint partnerships between the university and the hospital? That is also some issues that we are discussing right now. So what is 10 years? 10 years is, I think most of you know this one, but 10 years is, here in 2000 we had a dial-up modem, and 8 years later 100 million YouTube clips with 1 billion views per day. So this is our time frame. So we can't discuss this out of a technological angle alone, because we don't know. We don't know what technology there will be available for us in the future, but we can discuss which needs and which clinical processes and how will we deliver healthcare in the future. And then we're going to take that journey in an organic way with the vendors and private companies and, of course, the existing hospital to slowly move in the direction that is needed. Cisco made this, I think it was last year. This is also a thing we need to remember. This is they made a report on the future patient and how will they, or the existing actually patient, how will they adapt technology in communicating with their clinician. And I think it's 23% prefers a telephone consultation with a doctor, and 20% prefers a text message. It isn't that they would like to have it if they can't meet with a clinician. No, they prefer it. So this is not the future patient. This is the existing patient. That is us right now. So how will the existing hospital cope with this patient here? How will we deal with them in the new hospital? That is a key issue, and I think those numbers won't go down in the future. So in order to actually do this kind of communication with the top management of the hospital, the technological companies, and also for an IT strategic angle, we developed this method, and we called it Plan Down, Build Up, where we talked about vision architecture, where we decided upon our vision. Then we talk on goals, milestones, solution and architecture, and then data architecture. It's a brilliant, very, very, very simple model in order to talk about all these problems or issues, challenges that we face. Then we just had this communication template. So whenever we did some strategy work and making those goals and milestones, also especially clinical goals and milestones, we used this template, so every project needed to fill out one of those. And that's pretty good. It's simple, and everybody can understand it. And at every meeting, you're going to bring it forward, and then you're going to say, okay, right now we are in the second top square, and we're talking goals and milestones, and we are not talking actually solutions or activities. So it's a great way to frame the conversation that we are having. So our digital vision, and it's probably not only a digital vision, we also like to say that it's a vision for knowledge. And knowledge must be for all, to all, between all and everything, everywhere and always. Our digital systems should be available in this way. I think it's a great vision, you can remember it, and it also has some implicit goals within it. IT must be mobile on the new hospital, and they should start now on going mobile on all their applications at the existing hospital, because IT or knowledge can't be available everywhere if IT isn't mobile. So we have these implicit goals, no paper of course, because the knowledge must be available at all times, always, and paper, even though it's a great technology, can't do that. So we decided upon this vision, and then we did 9 strategies. We tried to do one big IT strategy, but that couldn't do, so we did some sub-strategies instead. We have a strategy for sustainability, a strategy for infrastructure, a strategy for tracking, and we're going to do a strategy for the digital ward and the strategy for the digital OR, etc. And we made these templates and filled them out with each strategy. And the VSEM, the alignment template on the bottom here, we also decided, okay, once we actually implement these projects, and it could be digital projects or organizational projects or managerial projects, it could be everything. But of course, a lot of them had a technical focus. Then we had to think about benefit management as well, or measurement. Because if we're going to reduce beds, we need to know if those projects that we're actually going to launch, are they delivering so we can reduce the number of beds at the existing hospital right now. So the template is actually like this, where we have vision, goals, and solutions, or solution architecture. And once all our strategies are in place, we can discuss how are we going to design an architecture that's going to support all of this. And then we're going to deliver the goals to the top management, or have delivered the goals to the top management of the existing hospital and our region, and telling them this is how we see the next 12 to 18 months. We are coming with the money, and we are going to, and you are going to decide and take charge of doing these projects that we are actually asking or saying that this is what we would prefer you to do. And some of them is located in our region, some are of national character, and some are very local at the existing hospital. And some of the solutions we can't implement before the new hospital is actually built. That is, one example is our logistics, and because we can't fit a modern logistics system into the new hospital, or no, sorry, the existing hospital. So that part has to wait. But as our goal is to as many solutions we can implement the existing hospital, the better. And in doing so, we are engaging in shared public-private partnerships. Elena, sitting right here, is from Microsoft. We just signed a memorandum of understanding last week. So we are actually doing those partnerships because we don't know what it takes, and you probably don't either, but together we'll figure it out. So we are going to do some clinical or some goals-oriented discussions, or we are going to do some technological discussions. One of them is give an example. Arthur Thummerfield here is a Postmaster General of the United States, or was. I think after the war, he probably met with his top management and said, well, okay, we have a vision, bring people together for the postal service, or a no sweetheart left alone, or something like that, and a vision. And he said, well, what are our strategic goals? What will actually be good for our business? And I think one of them is precision in mail. Precision that when I send a letter, it actually goes where I want it to. And they probably also thought about precision and also reliability, that the mail will go every time. And also speed. Once I send a letter, speed is essential. So he is definitely up in the goals and milestones area, where he decides upon a strategic goals and milestones for the mail or in the United States. I don't know if that's what happened, but then he moves downward into solution architecture. Looks, okay, which technology can actually give us speed, precision, etc. for mail, and here's a quote that I think he's famous for. And I must say, rocket mail, that's awesome. But that's a problem of only going from top down, because you only see the technology that's available right now. So you need to go from bottom up as well, or either you'll end with be very famous, like Mr. Summerfield here, but probably not always will you implement the right technology. Rocket mail. You can also do you can also do a technological perspective, and that's in our model. You go from the bottom up. So we say we have this technology. How can we use it? How can we use it in a different way? We can track everything. Equipment, of course. Let's track children admitted. Let's give an alarm if they leave the ward, or get more than X meters from the parents. That's a new way to use tracking. At least in Denmark it is. But that's not a technological question. That's a more one, or ethical. So it's more, if you do it from the bottom up, you'll see how will society, a region, a hospital deliver health care in the future. That's a big question we should all ask ourselves. because if you figure that out, then the technology that will come will support that, and that's going to be a sustainable way to use it. Otherwise, it will only be pilots that will remain pilots. So this is how we are working and will work with the existing hospital, with our existing region, in order to design a flexible infrastructure, some solutions that actually go into operations and not remain pilots within the next 5, 8, 10 years until we move out into our new premises. Of course, this is very hard. We have an existing hospital that is very much focused on economics and operations, of course. So once we talk about how will you deliver healthcare, it's hard for them to actually discuss it on a strategic or visionary level. Maybe not for the top management, but for the section leaders or department leaders, it's very hard to be in this strategic area. Either it's a visionary or it's going straight to the solutions. So our state forced change by creating a burning platform, and we are actually in the middle of convincing the existing hospital that they should create their own milestones and goals that are creating this burning platform for change. And then you should change by clinical goals and technological inspiration, like Mr. Sommerfield here, and also on the ward and tracking. So bottom up and top down way of discussing and communicating these things. And also we are actually opening a center called CIMT in Odense next month. It's called Center of Innovative Medical Technology, and it's a collaboration between the university and the hospital. And that's because more and more our clinicians demand evidence that our solutions work, but also how would this technology influence my clinical practice, my clinical workflows. And if we really are changing those, the clinician wants evidence, and that's pretty much a good thing. That's how would they affect it? OO plus NT equals COO. That's Hal Wolf from acquaintance of mine from Kaiser Permanente. He used to say that to me, and it means old organization plus new technology is costly old organization. So we need to change not the only how we use technology, but the organization as well. In my line of work and in my experience in the hospital business, we very rarely focus on benefit management. We have no idea what the technology is actually influencing the clinical work. We have no idea. We spent a lot of money introducing electronic healthcare record. We do not know what it did, except that they had easier access to information. But if we because sorry, but because we have established this burning platform, we need to focus. That's a terrible ringtone. Sorry. We need to focus on benefit management because we have to harvest. We have to harvest those benefits that these IT systems will give us. So we have to do it in an analytical and structured way. Engage in public-private partnerships. I don't know I only know the road and the direction. I don't know what we are gonna meet on the road. And in order to do that, I'm traveling a lot to see other hospitals, traveling a lot to see solutions in order to be able to know what can be done. But it also means that we need to take each other's hands and walk forward together. And we do that with Microsoft at the moment. And also have a problem-oriented view on IT projects. It's not about the next project. It's about the network of knowledge, as I wrote here, in the clinical process of tomorrow. So if you focus on problems instead of the next project, you will actually also define solutions that's going to bring you in the right direction that is not a technological solution. And that's pretty good because we need everything to succeed on this because we all face the same challenges of more elderly, lesser funds, and more chronic people. So get together and take the path together. Amen. Thank you.
Thank you, Jonas. So we definitely have a couple of minutes to get questions from the audience if you have any questions. Otherwise, Scott and I will ask some question to Jonas for this. Please.
It's Christine Miles from the UK. Just wondered how you had involved patients and other partners like social care in your, your vision.
In our vision, IT is for everybody, and that includes the patient. So when the patient needs to, we need to be able to deliver our healthcare to the patient wherever they are. So if they are on a trip somewhere in Denmark, we need to be able to reach them and give them the correct healthcare services. Of course, it doesn't involve operating, etc. So we actually have patient panels, and we invite patients into our strategy groups as well. So they sit with at the table and discussing not solutions, but where would we like the healthcare that we are receiving to be within the next 2, 3, or 4 years. So we definitely invite them in, but I think we could do it more. Sometimes we see ourselves as both an expert and a patient, so yeah.
Interested also, following on from that point, about the clinical involvement, especially in terms of following on from vision and goal setting, especially around the, I think you said effective outpatient usage is 7 hours a day, 245 days a year, which means 5-day working. And I think in the UK, there are thoughts around kind of increasing, especially you've got the opportunity to build and kind of have new. And in the UK, I think we're thinking about, well, actually, we should be using our resources more than 5 days a week, and for probably longer as well. And there are some good examples of hospitals that are doing that. So I just wondered, where was the clinical involvement, and how did you come up with that specific goal?
The state did that. And they called it a board of experts. And for me, those numbers could be greater, because that's a gift. That's a gift of change. But of course, when we discuss it with the clinical personnel, they can't see themselves in this new environment yet. So I talked to a doctor the other day and said, well, those 7 hours, 245 days, it can't be done. So I won't even think about it. It can't be done. They have about 3 or 4 active hours a day today, and they are going to reduce the number of staff in summer holiday and also on Christmas. And if this is going to happen, they can't do that. So the great thing about this problem-oriented or the burning platform view is you could sit together with the doctors and lean personnel and IT persons and maybe human resource people, and they say, okay, we have this problem area here. We have these strategic goals. We have these burning platform issues. How can we get solutions that's going to bring us in that direction? And then everybody can share their perspective on the matter. But right now, we're in the middle of a place where the existing hospital must, they must adapt these burning platform issues and the milestones.
Regions, because the time scale you've got is long enough to encourage diversity,
Yes.
rather than implement convergence towards a single model.
We have, so to speak, freedom to decide which method that suits each region, or even though each building project.
And that may be the learning that we'll get from you.
Yeah.
Is what different things worked in different environments.
Yes, some people say that we should build our hospitals sequential. So once we build one, we learn, and then we build another, and then our project will take 50 years. But right now we are building almost at the same time. I think one of the other great or huge university hospital projects is maybe 2 years ahead of us. So we learn, of course, a lot from them, but they are being built at the same time, but different in different ways. And we tried to do, instead of deciding early on applications and solutions, we decided instead of designing a concept and a way to speak about it, and a process in communicating about technology and also about the clinical process of tomorrow. Yeah.
One more?
Jonas, Jan Huisman, the Netherlands. I just had a question. Designing solutions evidence-based, it's sort of variation to a theme. Isn't that a contradiction in terms? Talking about change management involving clinicians, it's obvious that you need to talk to them, involve them, etc. But evidence-based vision, solutions, etc. Help me out. How are you going to do that?
Well, we are starting on doing this SIM center, where we are going to attach a professor, and we have a budget of around 20 PhD students. So we need to measure and also do PhD projects on what will the effect of the technology that we are introducing to our hospital be. We're going to do PhD projects in a structured way, both in order to minimize the resentment of the clinicians, because they demand this. If we truly are going to introduce change to the clinical process, they want evidence. But also to make research in an area that we don't make much research in. There's really some fruits here that can be harvested. And I think it's strange that in an evidence-based hospital and healthcare area, we are introducing things that can change their processes, and we don't know if they work or how they work. We just do it, and we use a lot of money on it.
Okay, I think we have time for one more question, then Jonas will be around.
I'm also from Denmark and working in one of the other regions as well with some of the building projects. I was just wondering, you had a very good vision that's very similar to what I've been working with in the capital region. But what I see is also a lot of resistance and opposition outside the region to some of the goals that you actually put implicit into your vision. For instance, the security and privacy concerns in having access to everything everywhere all of the time to everybody.
Yeah.
And I see a big challenge in making that work in a way that actually is in accordance with EU directives concerning privacy and many other concerns coming in. But could you share some thoughts on that?
We have 8 years to solve that. No, yeah, that's correct. That's a vision. That's fortunately we don't have to go that much into detail in writing the vision, but yeah, that's correct. And of course the systems must live up to those legislations. And in Denmark we have this huge discussion in the last 15 years, and why do all the regions have different electronic healthcare records? Why can't you see data from one region to the other and just close them all and buy one for Denmark? We are only as big as Kaiser Permanente, they have one, etc. And then this year the state implemented a system where you can look at people's medicine info. So you can see what they have got a medicine from the general practitioner. You can take that medicine, drag it into your electronic healthcare record at the hospital, work with it there, and once the patient gets sent home, you deliver or release the medicine information, and the general practitioner or whatever can drag the information back and take ownership of it. And that is a really, really good example on how you can share healthcare data between these individual groups. And you know that it took a lot of, was a lot of articles and a lot of very important and high people that complained that what about the data integrity? What about everybody can look at the data? So it's you have to find a way to deal with this. So it's not either black, black and white. That was a very bad answer.
Well, I hate to cut the question and answer short. I know there are others. Jonas will be around for the next 2 days. I know he also has some leaflets he can share with you, and please feel free to grab him during the breaks and ask him more questions. Thanks again for the very interesting presentation.